Hi, everyone. It's Ray Berry. I'll be starting in a couple of minutes, 5 after 12. We'll give about two more, maybe 1 or 2 more minutes, and then we'll get started. Okay, we'll get started. Hi, I'm Dr. Ray Berry. I'm the division head of palliative care here at SHN. I also lead our community team. We follow people in the home. We have palliative care clinics. We have a hospice. So we've got quite a coordinated palliative care group here in Scarborough. Um, so yeah, thanks. Today I'm going to talk a little bit about nausea in palliative care. I'll share my screen. Hopefully I'm okay at doing that. Uh, is that is that sharing? Somebody just sort of let me know.
I don't see anything.
No. Okay. Um, I did practice on this. Now sharing? No. Yes?
Yep, I see it now.
February 8th, 2026, ECG shows sinus rhythm with low voltage period.
Sorry, I'm having trouble with this. I'm not sure if that screen is sharing. I don't think it is.
It looks like we can see your whole screen now.
Yeah. Okay,
Yep.
great. Let me just open up.
Yep, looks good here.
Good, great, thank you. Sorry about that. I'm not we're going to talk today about nausea and palliative care. I have this titled "Why ondansetron Isn't Enough." I actually considered titling it "Why ondansetron Doesn't Work." I see it so much for palliative care nausea. It does work, but just not for a lot of the nausea that we see. It's actually a very good drug for what it is, but it doesn't work for most of the nausea we see in palliative care. So what are the learning objectives today? We're going to recognize some of the common mechanisms. We're going to look at this from a physiology point of view. The mechanisms of nausea in palliative care and people with serious illness. We're going to use a real physiology-based approach to assessment and treatment. We're going to select targeted therapies that are based on these physiologic pathways. And then we will touch on, I will touch on some of the, I said newer therapies, although a lot of these have been around for a while, but talk about where some of the other medications fit into our approach. How common is nausea in palliative care? I see it all the time. The literature says 40 to 70%. And often the literature says prevalence increases as disease progresses. I don't really find it increases. It becomes very persistent, very entrenched, much more refractory. This is usually because the pathways have been activated and are sensitized and continue, and multiple pathways come into play. It's extremely distressing, say under-recognized. People don't talk about it as much as they talk about their pain or shortness of breath, but it's very distressing. When you really get in with patients, it's often even more than pain and other symptoms. It's often the one that really affects their quality of life. So very important to address it and find out the treatments that will work the most. This is just a very basic slide to remind you that nausea comes from multiple different areas. People think of nausea GI, it's very much a brain, gut syndrome, medications, metabolic, anxiety, vestibular. There are many, many different pathways that lead to nausea, and we're going to get into the details to a large degree of some of this physiology. It's just a little bit more detail on this to talk about where the different nausea pathways go. Metabolic causes, calcium, high urea, lots of little inflammatory proteins cause nausea. Medications very, very commonly cause nausea, and I'll be talking about the exact pathway of this. Opioids often implicated for this. Abdominal organs, actually bloating, slow down, constipation, directly stimulate pathways to nausea. Vestibular, we're quite aware of. Not very common with palliative care, but worth noting because people sometimes try to treat it, even though that's not the underlying cause. And then not well understood pathways. So I will touch on some of the pathways of this, but in the cortex and limbic system, I think we're all aware, when you're anxious or there's certain smells that remind you of things or anticipating nausea causes this. And these are direct pathways from the cortex and the limbic system. This is the probably key slide of the talk, and I'm going to spend a fair bit of time at it. These are the pathways. When you see nausea pathways, you'll see all kinds of different drawings of this to show all the pathways that connect into the brain to cause nausea. This is very simplified, but hopefully that's helpful rather than seeing all pictures of anatomy. Start in this very center of the diagram. This is often called the vomiting center. It's in the brain stem. Its actual name is the nucleus tractus solitarius, NTS. And this is where all of the pathways come together in the brain to make the signal to vomit. So multiple pathways all around the body, and we're going to get into which ones are the most important, send signals to this NTS. Then it's activated. And at that point, there's been so many reasons that the body says, hey, there's nausea here, and it starts to vomit. So this is where it's all coordinated. This is mostly mediated by something called substance P that was named a long, long time ago. It's such a historic name. But substance P is released in the NTS, and that is where the body finally says, okay, overwhelmed with signals of nausea, I'm going to vomit. So you can block that there, but it doesn't really block nausea, but it does block the vomiting at that point. I'm going to start right with what I think is the most important and the key thing out of this talk to look at as to where most nausea comes from in palliative care and why it's often mistreated. There is an area also in the brainstem called the chemoreceptor trigger zone. So this is where the body looks at all the things in the blood that says, hey, those probably shouldn't be there. I'm going to be nauseous and I'm going to want to vomit. They're not all necessarily toxins. Opioids are recognized at the chemoreceptor trigger zone as something the body probably wants to get rid of, but they're not actually a toxin. Other medications also bind here. Renal failure with high uremia activates the chemoreceptor trigger zone. Cancers often have all kinds of inflammatory cytokines, interleukins that bind here, and other metabolic problems such as hypercalcemia also connect here. So the interesting thing about this chemoreceptor trigger zone, it's in the brainstem as well, but it's outside the blood-brain barrier. So it monitors everything in the blood without it actually having to get through into the brain. It's a really amazing design. It's quite striking to me that that sits there and still signals everything to the brain, but it's in the brain, but accesses everything that's in the bloodstream. Once the chemoreceptor trigger zone is activated, it sends neurotransmitters to the NTS. The big transmitter, then this is where the main talk is going to focus. The main transmitter that's activated with all of these factors, opioids, renal failure, cancer, inflammatory cytokines. It's dopamine that's mainly released here. Also a little bit of serotonin, so neurokinins, but it's dopamine that's the main factor of nausea with all of these things. They're the main causes of nausea in palliative care. So if you're not addressing dopamine, you're really missing out. I will go through a few of the other ones that people also sometimes treat with palliative care nausea, but probably aren't focused on it. The chemoreceptor trigger zone, people think, well, chemo must be also really affecting the chemoreceptor trigger zone. Most chemos don't actually bind here. The molecules in chemo are a little larger and don't affect this. Where chemo causes nausea is actually in cytotoxic injuries. It causes cytotoxic injury, of course, throughout the body, but very, very importantly in nausea, it causes cytotoxic injury in the gut. There's rapidly propagating cells in the gut that are affected that release serotonin. These are usually the enterochromaffin cells. Releases serotonin, and through the vagus nerve, the vagus afferents, it sends serotonin to the vomiting center. So this is the primary effect of chemo. So for chemo, blocking serotonin is very important. In palliative care, much more minor effect by blocking serotonin. We talked about the vestibular system very quickly. It works in an entirely separate mechanism. It blocks histamine and anticholinergic muscarinic receptors, sends that directly to the vomiting center. So if it's vestibular nausea or motion sickness, blocking histamine and your anticholinergics will help with that. It will not help with any of these other nauseas. Limbic and cortical, smells, memories. The pathways are so poorly understood with this. There's a lot of cannabinoid receptors here that seem to block this. These are the things that are harder to grasp on. A smell that provokes nausea, a memory. Memories are really key. People go with their chemo, they start vomiting sometimes as they're just approaching it, just the memory of it. So there's other serotonin receptors here that mediate that, not nearly as well understood as the other pathways. So focusing back on the chemoreceptor trigger zone, this is the area that I said is outside the blood-brain barrier. There's a little diagram down in the brainstem. It's called the area postrema. Not that that's very important. It's important to know that it exists. Multiple neurotransmitters are involved with this, but again, the primary one is dopamine, and it's the dopamine 2 receptors. There are serotonin involved, substance P. Histamine is involved to a small degree, so blocking that with histamine antihistamines will have some effect, which is why people on antihistamines such as Gravol do report some improvement, but the main improvement comes with blocking dopamine. So the foundation for all chemoreceptor trigger zone driven nausea is dopamine blocking. As I mentioned, just to review, many nausea triggers in palliative care converge here. So medications, biggest one for us is opioids. Opioids cause nausea. Often people don't even want to take their opioids unless you treat the nausea that goes along with it. Metabolic abnormalities such as uremia from renal failure, very common that many of our patients in end-stage illnesses have renal failure. Increased calcium, cancer-related factors I mentioned, these all bind here. So this is where dopamine blockage is key. So what are the dopamine antagonists? We need drugs that specifically block dopamine. And I'm going to go through these in a fair bit of detail. The first class are prokinetic agents. So metoclopramide, Maxaran, and domperidone, Motilium. These block dopamine. And I'll talk about the specific interest in metoclopramide for this. The other class that blocks dopamine, which we all know, we don't always think of these as dopamine blockers, the antipsychotics. These are really historically called antipsychotics. I don't like using that in this talk because I'm using them as antiemetics, and many of them are not even used as antipsychotics anymore. But that's sort of the class that we will say, and we all know antipsychotics block dopamine. We know that when we're using, especially the first generation antipsychotics, we often get extrapyramidal side effects at high doses. So we know these block dopamine, and they are the actual most pure dopamine blockers that we have. So metoclopramide, I'll start with this. And the reason I'm starting with this, it's got a very unique action, and we use it a lot in palliative care for this. It does block dopamine centrally, so it crosses the blood-brain barrier, so blocks dopamine at the chemoreceptor trigger zone, but it's also effective peripherally at the D2 receptors in the gut. And it also actually is an agonist of serotonin in the gut. So those two increase gastric emptying. So this is the one drug that treats both, something that we see a lot in palliative care of decreased GI motility, often due to opioids, often due to decreased mobility. They're not moving around. So that often our patients have early satiety, just a feeling of fullness that causes nausea just by the direct effect on the gut. And then they also have the metabolic effect centrally on the chemoreceptor trigger zone. So metoclopramide does both. We often reach for this first. I didn't include it directly in here, but there was a study recently that studied whether it was fine just to start metoclopramide almost for all nausea in palliative care without looking at what the mechanisms would be versus trying to target it. And they found out that metoclopramide probably worked just as well as trying to target, even though the focus of my talk is to target. Metoclopramide hits almost very, very often the key factors that are leading to nausea and palliative care because of its dual action. Just mentioned its typical starting dose, 5 to 10 milligrams, if you're interested in that. The other nice thing about this is it can be given subcutaneously. That's very important in palliative care. Many of our patients are very weak, don't swallow well. And of course, if you have nausea, sub-Q administration is very important. I put avoiding complete bowel obstruction. That's just to also remind me to say, you don't have to avoid it in most presentations of partial bowel obstruction, which is what most presentations are when I see in palliative care. They're very rarely complete. They can be, of course. So if you see the signs of complete bowel obstruction, feculent vomiting or extreme cramping pain, then you avoid it because, of course, you're asking the bowel to contract against a blockage. But I use it with great effect with partial. I often see just the bowel is slowed down or there's partial compression, and it can really help relieve that by pushing through past that. So you don't have to avoid that. It's often avoided because people are afraid of bowel obstruction. But you can use it gently, and if the bowel is completely obstructed, you'll become clear and you can stop it. Metoclopramide as a dopamine blocker doesn't block the central chemoreceptor trigger zone nausea as well as pure dopamine blockers. The most pure dopamine blocker we have is Haldol. It's basically a pure dopamine antagonist. It has no prokinetic effect. It has minimal anticholinergic activity. People are sometimes surprised by this. They think Haldol is a sedating drug. It really isn't. It's been used so much historically for severe agitation that people think it's sedating. It isn't. It's actually one of the least sedating anticholinergics we have. Very clean because it doesn't have that anticholinergic activity. So when you need pure dopamine blockade, Haldol is the drug we reach for probably the most in palliative care. I will say it does cause a bit of confusion. It hasn't historically been thought of this way. I will often prescribe that on certain units. If I'm prescribing it with my palliative care patients, I think everyone knows, and people working in palliative care are very aware of it. But on other units, I do find that people are a bit confused by that. I'll often have nurses say, we didn't give the Haldol because they weren't agitated at all. So you have to do some education on why you're using Haldol for this. Sometimes patients get confused by this too. I prescribed it to outpatients, and they'll get a handout from their pharmacy telling them that they're on an antipsychotic, and I told them I was giving it for nausea, and I had a couple of people before I started to explain it to them ahead of time feel a little offended that I was thinking they were psychotic and needed this. And so I explained that this was a historical use of this. There are other ones. So I focused on the ones that you probably both need to know, the most pure dopamine blocker, which is Haldol and metoclopramide. There are other antipsychotics. The most well-known for nausea, prochlorperazine, which is trade name Stemetil. It's most well-known for nausea because it was marketed for nausea. The drug company had a very bright idea. They knew there was a lot of phenothiazine antipsychotics on the market and thought, hey, is there a niche role for us? So they studied it for nausea. It works the same as other dopamine blockers. Nothing specifically special about it. But because it does block dopamine centrally, it's great for this nausea. It is actually anticholinergic as well, unlike Haldol. So it's sedating. This is sometimes felt to be an okay side effect for treating nausea. People feel it's got an effect. They are nauseous. They sleep a little bit. It treats the central effect at the chemoreceptor trigger zone. So it's still good. I don't find it as clean as Haldol. I don't necessarily want to sedate my patients in earlier stages of nausea, so I don't use this. I find Haldol works really well at low doses. So, but feel free to use Stimatil. It still works very well for this. It's better than other options for most nausea and palliative care. I'm mentioning chlorpromazine because it's in this class. It's hardly used at all anymore for nausea. It was historically used, so people did know that dopamine blockers were very good for nausea. It's very anticholinergic. It also blocks alpha-1, so it drops your blood pressure. Not nearly as clean a drug as Haldol for this. Very sedating. I don't think I've seen it for nausea hardly at all now. People use it for the nausea associated with migraines, and you'll still often see that. It's good. The chemoreceptor triazone is quite sensitized to migraine, so blocking helps that. And the sedation is actually welcomed as you're recovering for your migraine. So chlorpromazine, as far as this class of drugs, does have some use for nausea, but only if you really want to sedate. I'm going to mention methyltrimeprazine, which is trade name is Nosenan. I don't think you'll see that at all unless you're dealing with a palliative care specialist. It is a very strong dopamine blocker, but it blocks almost all the receptors. Very strong anticholinergic, strong histamine block. So it's very, very sedating. It's such an old antipsychotic that it was actually going to be brought off the market a few years ago, and some of the palliative care community rallied to keep it. The reason we like it so much is it's very useful at end stages. It blocks all the receptors, so it really calms down everything, calms down all the things that are firing at that point. Blocks nausea by blocking the D2 receptors. The strong anticholinergic effect, which we try to avoid earlier, is actually quite welcomed at end of life, dries out secretions, sedates. We find it very, very useful towards the end stages. So I'm just putting it up there. It's trade name often called Nosenan, in case you run into that. It's in this antipsychotic class, blocks nausea, and you may see it if you're dealing with someone that we consult on. Mentioning domperidone. Oops, sorry. It, unlike metoclopramide, only works peripherally. It does not cross the blood-brain barrier. So this is useful, not as useful as metoclopramide in treating nausea all around. So I don't use it as a sole medication to treat nausea. In those few cases, some of the people will ask, well, can you give the Haldol and metoclopramide together? What's the extrapyramidal side effects? I really never see that. I've seen it one time in my whole career because we use such low doses of Haldol for this. But if you ever did see it or you were concerned about it, and of course there are patients that can't tolerate any extrapyramidal or extra dopamine blockage, or obviously Parkinson's, Lewy body, we wouldn't give that. So domperidone can be useful there because it doesn't cross the blood-brain barrier and helps with that early satiety. There are the second generation antipsychotics, the so-called atypicals. The only one I think you need to know about, really the only one of this class that's useful is olanzapine. I mentioned the others because they do work and you might see them, but olanzapine is the one that people reach to in this. It's very, very broad in its receptor blockage. And so in some ways useful because although we try to target, and if we can target dopamine blocking, that's preferable. But if sometimes you want to block everything, so it's best. Often nausea is mixed, unclear etiologies. There can be anxiety, which is treated with olanzapine by the receptors it blocks. So it blocks serotonin receptors, dopamine receptors, histamine, alpha. It blocks across the board. So it's more sedating, of course, than Haldol then, with its anticholinergic effects. It's become very really risen in the treatments of chemo because of its serotonin blocking. So after chemo, it blocks both dopamine and serotonin. So well well regarded for this. Nice to have in your understanding where it fits and what mechanisms it's blocking. Can be given sublingually too, so that's very helpful. Anything that be given without swallowing oral for nausea is very useful. Low dose, 2.5 to 5 milligrams works quite nicely. So it can fit in. You may be trying with some of the dopamine blockers first, but this can fit in when there's a bit more of a mixed pattern. I'll mention briefly the other ones that in case you wonder where the other antipsychotics fit in this. Risperidone's a good dopamine blocker, but really no advantages over things like Haldol. So virtually never used for nausea. Quetiapine is sometimes used for nausea. It's more sedating. So if that's a factor that you want to bring in, and seems to actually help a lot with anxiety. So if anxiety and nausea together, it can be used, but really typically in this class, if you needed to go to this, you'd go with olanzapine. So back to the title slide. Why does ondansetron often fall short with the in palliative care? So it's a pure serotonin antagonist. Targets the peripheral serotonin pathway. So it's excellent for chemotherapy. So chemotherapy, radiation cause acute gut injury, release serotonin. It's fantastic for this, but not so much for chemoreceptor trigger zone driven nausea or metabolic or medication indications. So where I focused on this is I often see people referred to me and they've got bad nausea and they've been treated with ondansetron. And they're saying, why is this not working? What else can we add? It's not really what else can we add. It's what can target the nausea that is most central to what this person's having. So here, just focusing on the diagram I had earlier, cytotoxic injury releases serotonin through the vagus nerve. This is perfect for chemo. So ondansetron is amazing for chemo. It works well. Other medications also work for chemo, blocking this neurokinin receptors, also working out well for chemo because that's activated through the serotonin, but doesn't work for all the other things that we saw that are primarily the causes of nausea in palliative care. I'm going to talk about just the other medication classes and where they fit in, and then I'm going to do a bit of a case to show how they could all fit in together. Lot of interest in the neurokinin antagonists. Aprepitant is the main one that you'll see orally. There is a IV version as well. So where this works, as I just showed you, it's in the NTS, right in the vomiting center. So in there is substance P, which is released. Substance P doesn't start nausea. As nausea persists, the amplification becomes important. So it's a signal amplifier. It amplifies all of the signals that come into the NTS. It does exist very weakly in the chemoreceptor trigger zone in the limbic systems, but primarily in the NTS. And it's released after the other nausea pathways activate. So substance P binds at the neurokinin receptors, and at the point when it's been activated, it causes vomiting. You'll see this used a lot in chemo induced vomiting, and it's very effective in delayed nausea. And the reason it's useful in delayed nausea, so you may have seen with chemo, there's an initial nausea, but sometimes after, a few days later, vomiting really persists. It's this delayed vomiting after chemo. So why aprepitant is good here is that it's when the system's been sensitized, the serotonin has activated at the NTS, and substance P is just turning out. So you may have blocked with ondansetron, you may have blocked the serotonin, but substance P is still going on, and so the vomiting continues. So it's very effective to turn off that gate at that point. Corticosteroids, very well used in nausea. They don't block nausea receptors. They block inflammation, as we know. So inflammation really sensitizes the system. to the neurotransmitter sensitivity. So cytokines that are released with inflammation, often with cancer, they sensitize the chemoreceptor trigger zone. So it enhances the effects of dopamine, serotonin, substance P. So think of it as a potentiator. It's not that useful on its own. A little bit. There's a little bit of effect on nausea by just decreasing inflammation on its own, but it's much better when you potentiate the others. So you're giving dopamine blockers or serotonin blockers, and it potentiates the effect by changing the neurotransmitter sensitivity. The only time that they're useful directly, which I didn't talk as a clear mechanism, but it is a very specific mechanism, is directly on brain swelling or swelling of the viscera. So brain swelling, how does that cause nausea? We know the increased intracranial pressure causes nausea. That's actually just a direct effect. Pressure on those brain receptors, just the increased pressure activates them. So this is where corticosteroids would be a primary use for nausea, but it's very specific as a primary. Otherwise, it's used to potentiate your other treatments. Which one do we like with this? Dexamethasone is the one you'll see. It's the most pure, one of the most pure, potent corticosteroids. Very minimal mineral corticoid effect. Very potent. Can be given sub-Q. I've had some of my colleagues say, "Hey, everyone should be on dexamethasone. It decreases inflammation. It makes the other drugs work better. Why don't we give it to everybody?" We don't give it to everybody because, of course, there's many side effects to these corticosteroids. Makes them difficult to sleep. You have to give it in the morning. Luckily, this can be given once a day. We always give it just in the morning. It causes delirium and all the other side effects that you're well aware of. Hyperglycemia, immunosuppression. These are not always that relevant in palliative care because the life expectancy is so short. So we're more likely to give it than in earlier stages. But there are many side effects, so we don't reach to it right off the bat, but it does have a role. Lots of interesting cannabinoids for nausea. Not really well understood yet, although we're learning a lot more about the receptors. This would almost be a whole talk on cannabinoid receptors. There are a couple of main ones, CB1 and CB2. The cannabinoid 1 receptors are widespread throughout the brain, throughout the NTES, the chemoreceptor trigger zone, hypothalamus, limbic system, and it seems that they have a dampening effect. So when they're activated, it seems to just reduce the neurotransmitter release. So this just calms the whole system down. It's very effective for anticipatory nausea. It has a strong effect on the limbic system that seems to be very important in that dread that you get or anxiety that provokes nausea. Seems to calm that down quite well. So we use it as an adjunct to other treatments at this point because it just seems to calm down the whole system, and that can be very helpful. I won't get into the physiology of the appetite effect. It's separate from its nausea effects. It does activate receptors, hypothalamus, increases hormones specifically for hunger. This can be a very big quality of life improvement when people can eat a little bit better. So cannabis does have a role for that, for those who feel like eating would help their quality of life. It doesn't always improve quality of life in palliative care, but for those that it would, very helpful. You can prescribe cannabis. There's lots of ways to prescribe this now. That would be a full talk to talk about how to prescribe cannabis. Most simple thing, if you're not comfortable prescribing actual cannabis, which comes in different oral or inhaled, is to prescribe nabilone, which is a capsule that can just be ordered pharmacologically. So 0.5 to 1 milligram of that. That's a very nice way to give it. Downsides, of course, sedating, cause some dizziness, of course, can cause some delirium. but generally fairly well tolerated. I have to talk specifically about Gravol. It's got such a limited role. I still see it often prescribed. People reach to it as sort of the first nausea medication to reach for, and nausea. I've been called many times by different places I consult. I consult a little bit in long-term care. They're often saying, "Hey, we've given Gravol for the nausea." So Gravol, it's a histamine antagonist, also very anticholinergic. This works only really on the vestibular pathways. A very, very mild effect on the chemoreceptor trigger zone, but basically it doesn't address this. It adds significant sedation, which again, if you're nauseous, sometimes makes you feel better. You fall asleep. Causes all the strong anticholinergic side effects that we don't want to give. It doesn't address the root causes of nausea in palliative care. So really very, very limited role. If somebody had vestibular nausea, I suppose it could add to this. They could have inner ear disease, but very, very rare and should essentially not be prescribed. So I'm just going to go through a case. This is the case that shows why mechanisms matter. 68-year-old male with pancreatic cancer, liver mets, opioids, and ondansetron is where I saw this person. Came in with this and was presenting with worsening nausea, some vomiting. Tried to take a history, and where the history is important here, it's not just history, it's trying to find out what is the mechanism that's behind this. Nausea was present all day. He found worse with any smells of food. Early satiety, abdominal fullness, but bowels were moving well. Felt fatigued, and quite importantly, no vertigo. So we would not go there. So here, the history again. What are the dominant pathways? That all-day nausea, that persistent, that's almost always chemoreceptor trigger zone activation in the absence of some specific triggers, such as being on chemo, where the serotonin would be activated. But that persistent all-day nausea, that's where we have to really get to that chemoreceptor trigger zone and the dopamine. The food and the smells, that's in the limbic cortical system, and we'll talk about how to address that through which we already have, but we'll go through it in a case. Early satiety, very common. People just aren't moving around, and the bowels and gastric system don't move well. Opioids, almost a great majority of my patients are on opioids, and so therefore the chemoreceptor trigger zone is activated with dopamine. The cancer itself has an inflammatory state, edema, cytokines. There's no vertigo, so it's not vestibular. So why ondansetron didn't work? Of course, we know this. He tried ondansetron. We reviewed this a fair bit. Serotonin is not the dominant transmitter here. And ondansetron is best for acute gut, serotonin release, chemo. So the failure of this actually helps guide you that this is not what's going on, and it guides you towards the chemoreceptor trigger zone. So if serotonin is not the main signal, blocking it won't have any effect. So we want to trust the chemoreceptor trigger zone with dopamine blocker. And here, just to show you where metoclopramide fits, since there's also a component of decreased gastric motility, metoclopramide is a good choice. It increases the gastric emptying, it crosses the blood-brain barrier, so it's a central dopamine blocker. So this was where, in this case, we started with this, and it's often the place we start. And in this case, he started on this, and he felt that the fullness and his early satiety improved, but he still had nausea. Why is this? Metoclopramide is just not as strong a central dopamine blocker as some of the other medications that we talked about. So we want to use a more potent dopamine blocker. And this is where we added haloperidol. And I say I added haloperidol, and This might flag things if you do this and add this to metoclopramide because of the additive dopamine blocking. People may say, or certainly actual programs that flag these interactions will say this could be a danger with increased extrapyramidal side effects. I said I find it extremely rare. I'm using Haldol at 0.5 to 1 milligram for this. That's almost always the only dose you need to really get the dopamine blockage you need at the chemoreceptor trigger zone. To get extrapyramidal side effects, you usually have to use the doses they used prior, I guess, for really calming, and sometimes still used for calming really agitated psychosis, 5 milligrams. So I will add to this. I will add Haldol to metoclopramide, but it would also be a reasonable thing just to switch off, use Haldol and use domperidone for the gastric motility. So at this stage, we did this and the nausea improved significantly, but he still felt just that general unwell feeling. And this is because the whole system is sensitized. He had nausea set in for quite a while, and there's an inflammation going on. There's edema, there's cytokine priming of the system. And the system's not just being triggered by dopamine, it's also sensitized. So we want to calm the whole system down, decrease that inflammation. Once the pathways are turned on, they tend to stay on. This is something you may have run into if you're aware of some of the physiology around chronic pain. You have to kind of turn off those pathways that have been locked on by constant priming. So dexamethasone would be very good to add at this point to just decrease that whole central sensitization and inflammation that's going on. Following up, just, and this is a complex case where we added multiple things to control. Most don't require this at this stage. Most nausea would be settled, but in this case, he still felt generally unwell. Had a food aversion, we thought, but he wanted to have some food, so we thought, let's further dampen the system. What else can dampen the system? The cannabinoids can do this. It turns down limbic activity, decreases anxiety, and we prescribed nabilone. It was easy to get, and it was well tolerated by him. And so he did this, and it improved appetite and felt much better. One other medication. So this is the final pathway, and this is the medication I use in palliative care really when I've really addressed the other pathways and there's still some vomiting. So this is, again, the system being primed. All the pathways have activated, and in the vomiting center, substance P is being released. And even though I've blocked all the nausea inputs, still there's some vomiting. And you just have to stop this. It just changes almost the behavior and settles down the system. So this is where I use the neurokinin 1 antagonist, so aprepitant at this point. So I added this at this point because he was still vomiting. I think it had just been so primed. So the background nausea then became more minimal because we were treating the pathways, and the vomiting stopped because we'd already blocked the upstream pathways, and now we closed that final gate. So this is where this is helpful at this point. So many drugs. I think one of the key things I take away from this is when I talk to people and they have their nausea is that I've got lots of different pathways to address. If your nausea is there, I can't always settle it down, but I'm quite confident that with multiple approaches, really trying to take a clear history as to what's going on, I can find one of the pathways that will address this. I really confidently tell people, don't worry, we're gonna control your nausea. We've got lots of things. So putting it all together, the key thing is identifying the dominant pathway. Look at through your history, and the dominant pathway is often the chemoreceptor trigger zone. We talked about which medications can address that and why it's so common, because it's medications, renal, hepatic failure, metabolic. So that's the key pathway that's almost always activated. But look at your other ones as well. GI motility, addressing that with motility agents if you need. Vestibular, increased intracranial pressure, a very specific cause. Treating serotonin blocking if it's indicated, but not if it's not indicated. And then treating anxiety, smells, anticipatory nausea in central with dulling those systems down. Didn't talk about this, but just mentioning it quickly in your overall approach. Obviously, if there's something contributing that's correctable, quite often we can't correct those underlying issues. I can just address the pathways. I can't always take away the cause. So if you need to be on opioids or there's different metabolic changes, I can't always change all of those, or inflammatory conditions. But if there are correctable causes, of course, address those. Constipation, some metabolic abnormalities can be addressed, hypercalcemia, remove smells, make the environment good. And then that's where you address the pathways. There's other ones that, other underlying conditions I can't change, but target your therapy. Really start with a scheduled agent for what you think the dominant pathway is, which is often the chemoreceptor trigger zone. And then, as went through the case, add agents with different mechanisms if needed, and reassess and switch the pathway if there's no response. So if I've given something that really blocks dopamine and it's really not working, consider what else might be going on. Maybe it is serotonin. Maybe there's something else going on. So don't just blindly add a different medication. Try to think, what other thing could I add at that stage? So thanks very much. I'm going to stop sharing. And yeah, thanks very much. We're going to have only 4 minutes. I'm welcome anytime for any questions on this. We're obviously very willing to consult on any time with complex nausea or any of your symptoms. Yeah, thanks everyone. Any questions? I'm still on if you want to throw anything or contact me anytime.